Hello, I'm Dr. Andrew Taruli. I'm the chairman of neuroscience at Overlook Medical Center in Summit, New Jersey, and I'm joined today by some of my colleagues from the Glasser Brain Tumor Center, and we're going to be discussing May, which is National Brain Tumor Awareness Month. The slogan that the National Brain Tumor Society has coined for this month is "Go Gray in May." And why gray? So let me read from the National Brain Tumor Society. So they state that the brain tumor experience is full of extraordinary darkness and extraordinary hope. The gray area that falls in between is what drives us unrelentingly toward our mission of conquering and curing brain tumors once and for all. So in this spirit, we joined together today to support, empower, and amplify the voice of the brain tumor community. So just to read some statistics from the National Brain Tumor Society, currently there are 700,000 Americans living with a primary brain tumor, of which 31,299 are adolescents and young adults. This year, 84,000 people will receive a diagnosis of a primary brain tumor. 70% of these will prove to be benign, and 30% will prove to be malignant. Approximately 80% of cancers can metastasize or spread to the brain. And more than any other cancer, brain tumors can have lasting and life-altering physical, cognitive, and psychological impacts on a patient's life. So at this point, I'm going to ask each of the members of the panel to introduce themselves.
Hi, I'm Nick Metrus, one of two neuro-oncologists at the Glasser Brain Tumor Center and one of only two board-certified neuro-oncologists in the state of New Jersey. There are only about 200 to 300 board-certified neuro-oncologists throughout the country, so with only two in the state, we're both under the same roof.
I'm Yaron Moshel. I'm one of the neurosurgeons and co-director of the Brain Tumor Center.
I'm Joana Emmolo. I'm the director of radiation oncology at Overlook Medical Center.
Thank you again for joining me, panel. So I'm going to start off with Dr. Metrus for just a little bit of an overview. Dr. Metrus, if you could, can you please tell us about some of the symptoms of a brain tumor?
So I think with brain tumors and with a lot of neurological conditions, it's not what you have, but where you have it in the brain that gives you your symptoms. So it's kind of hard to distinguish sometimes what may be the symptom of a brain tumor versus the symptom of something else, such as multiple sclerosis or even a stroke. So we have to take a look at the timing of which things happened and some of the other additional symptoms that may be experienced during that. So as you mentioned, there's over 80,000 people that are going to get a new diagnosis of a primary brain tumor this year, but a significantly larger amount of people are going to come in and see a doctor for a headache, which means that a lot of headaches aren't going to turn into a diagnosis of a brain tumor, but there may be some that do. So we look for other red flag symptoms that distinguish a usual headache from something else that may be something originating in a brain tumor. So things that we look for is maybe a headache that you always wake up with early in the morning, or headache plus, a headache plus weakness on one side, or a headache plus maybe some difficulty getting out the words that you want to say.
Thank you. So what about seizures? I've seen many patients over my career who presented with a seizure as the first symptom of brain tumor. How about that?
Certainly. Seizures can be one of the initial presenting symptoms of a brain tumor or a complication later on. A lot of brain tumors that are more towards the periphery of the brain are the ones that we often see that are associated with seizures.
Okay, so moving on to Dr. Moshel. At the outset, I mentioned the difference between benign and malignant brain tumors. Can you elaborate on that a little bit?
Well, in truth, any tumor and space-occupying lesion within the brain, it's hard to really classify them truly as benign, in that if it's in your brain, it's generally something we worry about. So there are a lot of tumors that biologically are benign tumors, but can sometimes still cause problems. Nevertheless, there are benign tumors that tend to be tumors that are located on the surface or inner lining of the skull, which are different than tumors that originate inside the brain from the primary cells of the brain that support the neurons. They're called the glial cells, versus tumors that sometimes metastasize to the brain from other cancers. Generally speaking, the tumors that are on the surface or within the lining of the brain, they're also called the meninges, which comes from the Latin word for the lining or the wrappings of the brain. Those are the tumors that tend to be more benign, whereas tumors that originate within the substance of the brain itself tend to be more aggressive. Sometimes those tumors can be overtly malignant, or sometimes they can be tumors that we consider as the precursors to a future malignancy, and we call those low-grade tumors.
Thank you. So, Dr. Metrus, I also discussed or briefly mentioned the categories of primary and metastatic brain tumors. Can you elaborate for our audience what those are?
Sure. So, with a primary brain tumor, this is a brain tumor that originated in the brain. It didn't come from somewhere else. And by and large, those tumors are not going to go anywhere else. So we have to come up with different terminology. You may have family members that have had cancer where they talk about stage, like a stage 4 breast cancer, which means that it's widely metastasized to the body. Whereas in the brain, since it doesn't go elsewhere in the body, we had to come up with different terminology to use. So we actually use grade to tell us how aggressive that tumor is going to be. So a primary brain tumor is a tumor that originated in the brain, and a secondary brain tumor or metastatic brain tumor is going to be something that started elsewhere in the body and then went to the brain as a metastasis. Sometimes people who have a metastatic brain tumor may not know that they have a primary cancer somewhere else in the body, and that may be the original symptom that they find. But the cells that we look at underneath a microscope after it's been taken out may still look like the original tissue of where it came from. So for example, someone with a lung cancer that had a metastasis to the brain, that tissue won't necessarily look like brain tissue. It will look like brain tissue, but intermixed in there is lung tissue.
Okay, thank you for clarifying that for us. So, Dr. Emmolo, can you tell us about some of the risk factors for brain tumors? There's been a lot in the news and popular press about cell phone use as a potential risk. So if you could discuss for our audience some of the risk factors for brain tumors.
Unfortunately, the overwhelming majority of brain tumors we don't know the cause of, barring rare hereditary issues or previous history of radiation treatment to the brain. We don't really know the root cause to most brain tumors. Cell phones, exposure with that. There are many studies that have been done, nothing conclusive, nothing that says that there's any direct link. And the idea there is that there's radio frequency waves that potentially could cause abnormal changes in the DNA and the underlying brain tissue, especially if you're holding the phone up or you spend a long time with the phone up to the ear. But really no data has substantiated that that is a risk factor for brain tumors.
Thank you. So let me talk a little bit about care for patients with brain tumors. So Dr. Moshel, let me ask you how you work in conjunction with other team members in the Glasser Brain Tumor Center to deliver world-class care for our patients with brain tumors.
Well, I think one of the main points of the Brain Tumor Center is to deliver what we consider multidisciplinary care. So what you're seeing here today is our members of the team, and we have a larger team where we really bring together different specialties, and we try our best to really take care of patients almost as a family. I and Dr. Frizzoli, one of our junior neurosurgeons, kind of function as the neurosurgeons, but really we work closely with our neurooncologists, Dr. Metrus and Dr. Aiken, and with Dr. Emmolo and Dr. Ryu from radiation oncology, and we really integrate all of our care. So what we try to do is not make the patient's treatment sort of happen in multiple little bubbles, but rather we come to the patient and we'll see the patient together and their family in one visit at one place, where the goal is really to ease their family's minds and really let us do the heavy lifting and the organizational work and take care of everything for the family. Generally these patients and families have enough on their mind that the least we can do is all work together and take care of a lot of the organizational details for them.
We have a number of unsung heroes among us too, right, in terms of having social workers, dietitians, really tremendous amount of support to step in, research navigators, a nurse navigator, really to help the families in order to cope with the new diagnosis and with the treatment and the side effects and everything that comes along with it. Cancer is a burden, and it's something that needs to be shared amongst a number of people in order to make the whole process a little bit easier.
So Dr. Emmolo, tell me about that. You mentioned navigation. Tell me, what is a navigator? That might be an unfamiliar term for some members of our audience.
So actually a navigator helps the patient really to travel between the between the services, get everything, all their appointments scheduled, have things done in a timely manner. If they need an MRI, to have the MRI set up. If they need follow-up with a certain physician, nothing slips through the cracks. They don't have to worry about, did I forget to do this? Or and maybe they just need someone to talk to that day. They need someone to vent to. It's another set of ears and someone to remember what steps and what things need to be done. Without the navigator, you wonder how people can really keep up with everything that needs to happen. It's really an invaluable component of the program.
I think one of the most compelling descriptions that I heard from a family member about the role of the navigator and what we do for them at the Brain Tumor Center, it was they basically said that on that first visit after surgery, when the family's really coping with the diagnosis, everyone comes in to the visit with research that was done on the internet. Everyone has notepads and they're all ready to take notes. And somewhere throughout the process of that visit, what they said was basically we all had to put our pens down because we knew that you guys were just going to handle everything. And I think that transition in the mindset of the family and the patient is really what the multidisciplinary concept is about, and really the role that the navigators play.
That's great to hear that you can provide a service like that for our patients. That's fantastic. So just in terms of integrating care, let me ask Dr. Metrus about a tumor board. So this may be another term that's not familiar to many members of our audience. Can you explain what a tumor board is and how it works?
Sure. So imagine that you're newly diagnosed with a brain tumor and you need to get that expert opinion not only from one member of the team, but the whole multidisciplinary group. So this is another place where that multidisciplinary idea really shines. We sit together and we'll talk about each patient's individual tumor, and that's in a room or a virtual room as it's been for the last couple of several months, where it's a radiologist, the neurosurgery team, the neurooncology team, the radiation oncology team, a neuropathologist, and then the rest of our support group helping to take a look at the MRIs, the scans that have been done of the brain, taking a look at the pathology, the actual way that the tissue appears underneath the microscope, and then talking about the meaningful treatments that we can offer and whether or not each one of those patients would be a candidate for one of the clinical trials we might have, or whether we can tailor the treatment specifically to that patient based on what we know about their tumor tissue.
So our tumor boards actually evolved a lot, and I think that's a point that I would like to make, that Dr. Metrus has actually really helped push our tumor board to a really high academic level. Because, as surgeons, we often look at MRIs from a geometric perspective and a neurofunctional perspective. I think when Dr. Metrus looks at that MRI, he's looking at it from a slightly different variation from an oncology perspective. He'll look at the swelling in the brain, try to make his best guess on the biology of what's going on, and really try to help cater the treatment to the patient. And in the same vein, Dr. Emmolo and her team being part of the tumor board really adds tremendously because they're looking at it from a radiation oncology perspective. What extra areas are going to have to get radiation in ways that, let's say, a surgeon and even a neurooncologist might not look at it. And the value of the tumor board is that we bring all these ideas together. And I think one of the great things that Dr. Metrus has helped us do is really coordinate all the opinions in tumor board and come up with an official tumor board opinion.
I think that's especially meaningful to the patients because not only has one doctor taken a look at your case, but a whole room full of doctors have taken a look at your case, all coming from different backgrounds and different specialties and offering expertise to give you the best level of care that we can.
Yeah, it's great to have that kind of support and that kind of cross checking of your colleagues to make sure that you're making the most informed decisions for your patients. So let's just explore what you mentioned about tailored treatment, Dr. Metrus. So when you're looking at somebody with a newly diagnosed brain tumor, a malignant brain tumor, what are some of the things that you are interested in when you're trying to tailor therapy, a chemotherapy regimen, for example, to one of your patients?
So let's take the example of glioblastoma. What Joe Biden's son Bo passed away from, what John McCain had, the drummer of the rock band Rush passed away from. This is a diagnosis that has evolved a lot in terms of our understanding of what it means to have a glioblastoma, where now it's not just that diagnosis as the name glioblastoma, but we have to take a look at it at the DNA level as well. So not all glioblastomas are created equal. We have to consider the age of the patient, the location of where that tumor is, the name, certainly glioblastoma itself, but now also what mutations does that glioblastoma have? Because there's different mutations now that we understand can tell us about where did that come from? How long has it been there in the brain? How well will it respond to the certain chemotherapies that we use? Are there other mutations that we can actually use to our benefit as targets for different kinds of chemotherapy? And is that patient going to be a candidate for one of the clinical trials that we have?
So, when you practice this branch of medicine, you feel like you're always at the brink of the next major breakthrough. And I think all of us today really feel that that is going to be the next major breakthrough. We're starting to see little bits and pieces of it come to fruition, but this idea of targeted therapy and molecular diagnostics, really where every person is not just getting treatment for a particular cancer, but they're getting treatment for their cancer. And I think we're all excited to see that. We're certainly seeing it in other branches of oncology. In brain tumor oncology, it's a little bit behind because it's such a challenging disease. But that's really where we think the future is going to go. And in the same vein, we tailor a lot of our treatments, whether it's surgeries where we do functional mapping, and also a lot of it that Dr. Emmolo does in how she designs radiation treatments.
So let me talk about that radiation treatment. So Dr. Emmolo, can you talk to the audience a little bit about Cyberknife? What does that involve?
So we use Cyberknife at Overlook as a verb. We're going to Cyberknife that. It's actually the name of a very sophisticated machine that allows us to deliver pinpoint, high-dose targeted radiation where we can really target the tumor and protect the normal surrounding brain tissue, maximizing our chances at controlling the problem and minimizing the side effects from treatment.
Dr. Emmolo, could you tell us about the history of Cyberknife at Overlook Medical Center, please?
Sure. So Cyberknife has been at Overlook for about 17 years now. We were the first on the coast, 13th in the world to adopt the technology. We're actually on our second robot. We have all the bells and whistles on this newest edition, and it's really been the center of our program.
So actually, they actually have an amazing team in the Cyberknife. They have tremendous experience, and I still remember back in the time when Overlook was one of the few places that had the Cyberknife program, and it's a technology that even I wasn't terribly familiar with. And now, you see advertisements for Cyberknife all over the country, and it always makes me very proud to know that the team at Overlook probably has some of the largest and best experience in the country.
Okay, so earlier, Dr. Metrus, you mentioned something about clinical trials that you have available on the cutting edge for treatment of brain tumors. Can you tell us about some of the clinical trials that are currently available at the Glasser Brain Tumor Center?
Sure. We have different clinical trials that are tailored to different kinds of tumors, and as I mentioned before, each of those tumors may have different kinds of mutations. So we know that in some tumors, they have mutations that show that they're going to be more responsive to our standard of care treatment, the gold standard combination of chemotherapies and radiations. But for other patients, they may not have those mutations that show that they're going to have as good of a response to that. So we want to be able to offer them something else. That's where clinical trials come in. It's a more experimental therapy that may pan out to be the next best thing, the next standard of care. But we won't know that unless we try to push the boundaries. And that's what we're trying to do with clinical trials. So if one example would be with immunotherapy, which has been really successful in other kinds of cancers, where we basically trick the immune system into treating that tumor like an infection. And we tell the immune system, go attack that as if it were a pneumonia. And it's panned out very well in some other kinds of cancers, and so we're trying to see if that will be successful in our brain tumors as well. We also know that there's new understanding of other kinds of tumors, diffuse midline gliomas, brain tumors that occur more in the midline of the brain. And if they harbor a specific kind of mutation, we know that that mutation might be more responsive to a specific kind of drug, ONC201. And so we're using that to see if we can give those patients who may have a more aggressive kind of tumor some extra benefit with that medication.
So that example is a great example of what we were talking about earlier with personalized medicine and targeted therapy. So that's what Dr. Metrus was referring to, is a specific type of tumor with a specific mutation, and they're actually organizing treatments based on that mutation and targeting that subtype of tumor specifically, which I think is very cool that our neuro-oncologists are doing that.
It's interesting and encouraging stuff. So, Dr. Moshel, we've heard about some of the recent advances in radiation oncology and in oncology, the medical therapy of brain tumors. So, can you tell us about some recent advances in the neurosurgical arena for treatment of brain tumors?
The challenges in general with neurosurgery and brain tumors is we always ask the question is how can you do this surgery less invasively? And at the same time, as much as you want to do it less invasively, how can you maximize the safety? And also, how can we do more complete resections of the tumor? And sometimes those individual goals counter one another. So there are areas of the brain where you try to take more of the tumor out, but you're very likely to cause harm. So all of that is a challenge. Some of the technologies that we're using to help us achieve this, one of the very novel, cooler new things that we're doing now at Overlook is the idea of fluorescent surgery. So it's also known as the pink drink, which a couple hours before surgery, a patient would ingest a drink that contains a chemical that basically gets absorbed by the tumor, and with a specialized microscope that has the right light source and fluorescent capabilities, you actually can get the tumor itself to glow pink inside the person's brain. So that's helpful in that traditionally in neurosurgery, you're always looking at an MRI, and the surgeon in their mind is reconstructing what that MRI means and then translating it to what they see in front of them. This actually allows direct imaging within the patient, so you're actually seeing the outline of the tumor in the patient. So that's been very helpful. It's a relatively new thing. But other things that we do to maximize safety, sometimes we do things where the patient is awake during surgery, so we can make sure that we don't damage their speech centers. Sometimes we'll do electrical testing of the brain where we'll stimulate parts of the brain to make sure that the circuits are working and that the telephone cables are all still connected and that movement is okay. And then the last bit of technology is really the idea of image guidance, where we have kind of integrated computer graphics of the MRI together with the instruments all being tracked by a special camera. It's kind of like a GPS system for the brain. It shows you where you are in the brain. But we take it a step further where what we do is it's called volumetric surgery. So instead of treating tumors as these point in space dots on a coordinate map, we actually try to think of a tumor as a three-dimensional volume and try to remove that volume in one piece. So those are some of the changes that we're seeing. And there's actually a lot of overlap in that technology with the technology that's used in Cyberknife and in radiation targeting.
It's interesting, pink drink, I'll remember that one. So, Dr. Emmolo, a lot of patients with cancers are living longer than they ever had, including brain tumors. How does this inform your treatment decisions when you're designing a protocol for a patient?
So we're really trying to minimize exposure to normal, healthy brain tissue with the radiation treatment. We know the long-term effects can change the way a person behaves, the way they think, the way they act. And what we want to do is we want people to be living longer and living better. So we're really trying to target the tumor, trying to do a better job of getting the dose in where it needs to go and protecting everything else around it. So when we can avoid things like whole brain radiation and do this targeted pinpoint type of Cyberknife treatment, then we try to do that in times where we can't, where maybe the disease is too extensive. We can definitely try to spare certain parts of the brain which we know are at highest risk for changing the way people function later on in life, and doing more kind of sophisticated planning for that.
Great. So I'm going to switch gears a little bit and ask Dr. Metrus about paraneoplastic syndromes. So this is a little bit outside the realm of brain tumors, but it does fall within your discipline as a neuro-oncologist. So can you explain what a paraneoplastic syndrome is?
Sure. So as a neuro-oncologist, I started as a general neurologist, so seeing strokes, seizures, headaches, and then did additional training in how cancer affects the nervous system. So in addition to treating primary brain tumors, metastatic brain tumors, cancer can do very strange things to the nervous system sometimes. It's not the norm to have a paraneoplastic syndrome, but in certain cases, a cancer can produce antibodies that will go and attack normal structures in the body as if they are an infection or something that shouldn't be there. And in doing so, it can cause a number of different symptoms that manifest as neurological conditions. And so one of the benefits of having a neuro-oncologist in a practice is that, the term, when all you have is a hammer, everything looks like a nail. If my focus is to try to find the abnormalities in the nervous system in a cancer patient. So my view on trying to assess someone that I know has a history of cancer, I think I look a little bit more fine-tuned for those kind of rarities among rarities, or the paraneoplastic syndromes. So a numbness may not just be a numbness, or a dizziness may not just be a dizziness, and those have meaningful treatments that can help them.
Okay, and so there are a lot of different ways that cancer and its treatments can affect the nervous system, and some of them are within the specialties of other neurologists, maybe epilepsy experts or neuromuscular experts. So Dr. Metrus, how do you work with these other experts if you run into one of these problems? Neurology is very subspecialized these days, and not everything may be completely within the realm of one person to treat.
Certainly. But I think that one of the positives of having a neuro-oncologist is that if you have a neurological complication of your cancer, then you're not having to necessarily spend a lot of your time in waiting rooms of a bunch of different other doctors, where it's kind of that one-stop shop where headaches can be managed, seizures can be managed. In certain cases, though, I do lean on my colleagues that are more specialized in, let's say, neuromuscular. So if a patient needs an EMG to better assess one of these presumed paraneoplastic disorders, I may need to lean on them for some assistance there.
Okay, so let's just talk about some of the care that patients in the Glasser Brain Tumor Center receive. So, Dr. Moshel, somebody who's had brain surgery, that could be pretty serious. If there's are there any problems after hours, who do patients call? How do they get in touch with you to get the care that they need to address something that may have happened, related to their surgery?
Well, generally, all of us are always available as a team. If it's a specific surgical problem, most patients will call their neurosurgeon, so they'll reach out. They'll call our offices. We have a 24/7 service. But I think, again, that's the value of us working as a team. I know that, for example, when a patient's undergoing radiation treatment, I know Dr. Emmolo always has her eyes on them, because sometimes radiation treatments can take several weeks, and I know she and her staff will meet people every week formally, but they're always checking on them. And then similarly, Dr. Metrus is always chiming in and checking on our patients with his monthly visits and MRIs every 2 months. And the surgical patients always call me as well. But I think that's really the value of us all communicating. And then there's also more than us, in that we also have our navigator, who's also constantly in touch with patients and their families. So I think maintaining communication and staying on top of things is very important. And together as a group, we do that better than we ever could individually.
I think that really speaks to the Glasser Brain Tumor Center especially, because you have really high quality doctors, and I really enjoy working with these guys, that work in a smaller setting. So you're still getting high quality treatment, but it's not in this big cancer center setting. So it's more personalized. You're not necessarily just going to get a phone call from an assistant. You're going to get a phone call right from the doctor. And I made a number of phone calls just today, just to check in on patients and see how they were doing, just because the numbers are a little bit smaller, so we can keep our attention right on the individual patients.
That's a great commitment to your patients, and thank you for that. So, Dr. Emmolo, I want to follow up on something that Dr. Moshel said, and maybe I'll have you explain some of the side effects of radiation therapy to the audience.
So radiation treatment is targeting the tumor or the tumor bed and can provoke inflammation or swelling over the course of treatment. So frequently patients can have fatigue, headaches, potentially nausea or vomiting. We are seeing them, my therapists are seeing them daily when they set them up for treatment, and asking every day, how are you feeling? How are things coming along? Is there anything we can do for you? I see them at least once a week, if not more often, and have 2 nurses that are doing the same. So, we try to get in front of anything, any headaches that are persistent, to try to address them with some type of medication to help with that. But most commonly headaches, fatigue, potentially things like seizures and whatnot, but we really try to stay in front of these things and try to keep our side effects as non-dramatic as possible.
Okay, thank you. So I'm going to ask Dr. Metrus the next question, which deals with the integration of care again. So as the proud husband of an oncology infusion nurse, I'm going to ask you how you work with the nurses in our infusion center. What type of relationship do you have with them to make sure that our patient care is superb?
I think it's a very close relationship. I mean, my relationship with my wife is a little bit closer than my relationship with the other nurses over there. But we have clinics both at Overlook Medical Center and at Morristown, and we are doing infusions for patients at both locations. And so anytime there's any kind of question or complication with any of our infusions, our nurses are quick to let us know, and we have a very quick communication with them, so nothing goes unaddressed.
Okay, great, thank you. So this is really a fantastic program that's been built here, and I'm proud that this is at Overlook Medical Center. I just want to maybe finish up with Dr. Emmolo a question about some of the advantages of being treated close to home if you have a brain tumor.
Going through treatment for this is so hard as it is, so the additional complication of having to travel far or cross a bridge or sit in traffic or lose more time, and time is so valuable, just doesn't make any sense. You have world-class care in your backyard here, and we work really well together and really care about our patients and their outcomes. And again, it's so hard, and so the convenience really is very helpful.
That's great. Well, I want to thank all the members of the Glasser Brain Tumor Center, or at least some of the representatives we have of that center, for joining me here today. Thank you.